Caleb. Caleb. Okay. Hi. Can you answer?
Down here, up here.
You see more? What?
Passing it out.
Okay. Can everybody take their seat, please? And turn your cell phones off. Okay. Now that the speakers arrived, just as we get a quorum, we can begin this meeting. So I will officially call this meeting of the House Health and Human Services Committee to order. And
I move to thanks. Second.
Right. If we could just get his timing better, Mr. Speaker. So, Mr. Speaker, welcome to the House Health and Human Services Committee, the best committee in the House. My members are great. And you have the floor, sir.
Well, thank you very much, Madam Chair. I've heard a lot about this committee over the years. That's supposed to be funny. But thank you very much, Madam Chair, members of the committee, colleagues and friends. It's a real pleasure to be here today to discuss House Bill 1013, the Mental Health Parity Act, which I am proud to co-sponsor, along with many others, including Chairman Jones and Chairman Oliver. I want to begin by thanking all of you for the time and consideration that you've given this legislation. This is an important discussion. I think it's the most important we will take up this year. I have watched much of the testimony from your last two meetings and appreciate the thoughtful consideration and the questions and comments, input, both from members of the committee as well as those members of the public who offered testimony. This discussion, as I've said before, impacts most every family in Georgia in one way or another. Many Georgians are suffering with mental health issues. Their families are suffering. They're looking for help and either don't know where to turn or may in fact not have any viable option for mental health services. I have said and will continue to say that the number one state for business in this nation cannot and will not be among the worst for mental health care and access and quality. That's why I've called on two of the brightest, most determined and passionate members of our House on this topic, Chairman Todd Jones and Chairman Mary Margaret Oliver, to work together to carry this bill through the process. They have worked diligently to move this bill through the committee process, carefully considering feedback and suggestions, and offer revisions where appropriate. I cannot thank them enough for being willing to accept this charge, and they have represented our entire House with distinction throughout the process. I'd also like to thank the many co-signers of this bill from both political parties, because this is not a partisan issue. This is not a geographic issue. This is not an income issue, but leaders from both parties, including the Majority Leader, John Burns, and Minority Leader, James Beverly, and many other members of House leadership for being a part of this effort. I also want to thank the members of the Georgia Behavioral Health Reform and Innovation Commission, chaired by former State Representative Kevin Tanner. This bipartisan commission included mental health practitioners and advocates, representatives from the criminal justice system, and two of our own House members. And here I must stop and thank again Chairman Mary Margaret Oliver and Chairman Don Hogan for their service on this commission. This legislation will be paired with funding in both our amended FY 2022 budget and the FY 2023 budget to implement the provisions of House Bill 1013 and a host of investments in both public safety and mental health. In total, these investments will amount to approximately $100 million, $29 million of which is for House Bill 1013 alone. Should the committee choose to recommend this measure for passage, it will next move to the Rules Committee and then the House floor. And then it will go over to our colleagues in the Senate. So this is just the beginning of what I expect will be a multi-year conversation. We did not get in this place we are today overnight, and we will not get out overnight, but I can't think of a better big first step to take than this bill. We have yet a distance to go toward improving the care for and quality of life of many of our fellow Georgians. So I want to close by asking you to join with me in helping our state take a substantive, meaningful, and historic step toward reforming and improving mental health care in Georgia. I would ask for your favorable consideration of House Bill 1013. And Madam Chair, I would ask that you now recognize Chairman Mitchell for his motion. So. Thank you, Madam Chair.
You're welcome, Mr. Speaker. Would you take any questions from the committee if there is any?
I'll take one or two.
Okay.
Actually,
Do we have anybody on the committee that would like to comment or ask a question? Well, seeing, Representative Hutchinson.
Thank you, Mrs. Speaker, for this bill. I really, really like it. Everything in it is things that should happen. But what I've said in the committee before, my worry is that we're getting this great bill and putting it on top of the program. So that's just, the bill is great. I feel good being behind this bill, but my worry is still that we're putting a lot on top of the program. That's just
well, that's a valid observation. But if it's broke already, I don't think this will break it anymore. And so I think if we're going to bring about big reform, we have to start big. And that's why we did in this bill in doing that. So I make no apologies for it being a big bill, a major bill.
Are there further questions for the speaker? Well, I will say that one of the things is I've reviewed the bill with Representative Oliver and Representative Jones is that we have gone over it carefully and we have identified some of the places where there are lapses and holes, Mr. Speaker, to start rectifying that problem that we have. And so I think not only is this a great start with the overall issue, it will help us see how we need to change the system to make it more efficient. And I thank you very much
Thank you
for
very
your
much,
support of
Madam
this
Chair.
bill. Thank you for
Thank
coming
you.
to
You're
the
a great
committee,
champion.
and you're welcome anytime.
Thank you very much. It's not near as bad as I heard it was going to be.
I don't really bite. So thank you. All right. I think what you all decided, you want to hit the highlights of the bill, the changes that you've made since the last, and then you'll take questions. Is that my understanding of how you want to proceed? Okay, you have the floor.
Thank you, Madam Chair. I'm very grateful for this opportunity and particularly want to thank the speaker again for his leadership. Obviously, it's very meaningful. I have for over 25 years served the DeKalb Probate Court as county conservator. And what that means as a practical matter is that I have overseen the finances of mentally incapacitated adults, children too, but I'll talk about adults. The system works for significantly high percentage of mentally ill folks that have the correct kind of support, either the support of money that sometimes I'm able to provide, the support of family, or very often the support of good caseworkers. When somebody is alone and incapacitated, the Department of Aging of Georgia frequently as the petitioner in probate court to serve as a personal guardian. And I am tasked to manage the money under court supervision. That's given me a lot of practical day-to-day understanding of the way in which mentally ill people are more victimized than they are victims, creating other victims. A lot of my duty is to protect the financial assets and the independent ability to live with supports in society. One of my wards was a veteran was murdered by his caregiver in a group home that he was placed there by the VA. And I give those comments to say that of the 10% of Georgians, 10% of 10 million people who have some significant or mild diagnosis of mental illness, most of those people work well independently or served with a variety of supports. Our broken system is about the crisis, and the crisis centers and the ERs of Georgia and the money that we're trying to spend in an effective way is about the folks that are not being managed well periodically or consistently, and they end up in jails as homeless or in our ER system. And as we have gone through this bill in 3 different times of significant drill downs in the 3rd hearing, this has been a very good process for us, for Chairman Jones and I. We've probably received 30 to 50 requests for amendments. They are still coming in this morning, and they are thoughtful and specific and helpful. And I would like to hit the highlights of the amendments that we are asking for this committee's consideration. We've already incorporated into LC 3390S, and I believe we have 1 additional amendment that we would like the committee to consider. We had a series of amendments at our February 16th hearing. We adopted a series of amendments at our February 23rd. And last week or so, we have had an extensive discussion about transports, about pediatric coordinated care, about whether or not imminent harm is the correct standard. But let me go through the amendments that we are offering that address what I consider some of the most interesting and in the weeds and in the language of all of our funding proposals that we've all been tracking as this bill has gone forward, to show you where we are today and ask for your consideration. The discussion about whether or not somebody can be taken into the control of the state based on a psychiatric crisis of imminent harm has been a very valuable discussion in Georgia and has tracked the national discussion. And it is appropriate for us to think thoughtfully about changing that standard. And in the amendment we offer today on page 49, line 1231, we are adding some additional criteria. As we remove the word imminent, we are adding additional criteria to determine whether or not the Georgia standard, the Georgia law for taking someone's civil liberties away, taking them to a crisis ER or a crisis center is appropriate. I believe as this national discussion goes forward, that the way this language is offered goes the path of how we need to redesign and redefine. And I'll go back to as our own observations in our community of the homeless man or woman, or the homeless woman with a baby outside, that the standard of imminent, immediate harm is too great, and we have to give more flexibility based on a broader criteria. We also had a long discussion about transports. And I will say again that subsequent transports after a mentally ill person in crisis has been taken to an ER or a crisis center, and he or she is determined under 1013 to be in need of treatment, and where should he or she be transferred secondly. It's the subsequent transfers that have given us the most time and opportunity to look at solutions. Across Georgia, there are a number of different public-private entities that are contracting with a wide variety of folks. And one of our amendments is to allow Criminal Justice Coordinating Council to make grants to determine a support for additional subsequent transfers. And another amendment, that's on page 51, and on 56, we are asking the Office of Health Strategy and Coordination to do for us a real analysis, because I don't believe we have all the correct information. This CSB says they do transports. This CSB says they don't. The private CSB in Bradley Center in Columbus says they do. And I'm very aware of the statutory and authorization that exists and the opportunities that some medical facilities have taken. So I think that the bill allows some additional funding for those areas that might be lacking or want to have a new way. And Jay Neal is somebody that we all know and trust and has done a really good job with the Criminal Justice Coordinating Council. The pediatric registry was removed in our last sub, and we are reincorporating that in a different way based on the, again, the advice of CHOA, Children's Health of Atlanta. And we believe that the determination to provide a care coordination methodology under the Office of Health Strategy and Coordination is the best way to go at this time. I think that CHOA and perhaps some other private entities would like to participate in funding that survey. There is a necessity. Again, we're talking about children basically under 21 in crisis, and where those children are being repeatedly in and out of the emergency room and not being treated well. Let me go also to repeat something I probably have said before. The 2 million children in Georgia, there's 10,000 that we are directly responsible for, 10,000 plus or minus foster care children that we in this building, across the street in this building, are responsible for, whether they get a basketball summer program, whether they get to go on the bicycle ride across Georgia. We make those decisions in terms of funding and oversight. And those foster care children that we are responsible, that are not getting health care in and out of those emergency rooms, is something that this care coordination team really needs to work on in a more productive way. We're including the reference to the new advanced directive for psychiatric care on page 42, line 1086. As one of the tools that can be used in terms of providing care for people in crisis. And I've done, and we've talked together about the duplication of some study efforts in relation to the councils and task force that are set forth in this very long bill. You know, we create task force and we create councils because there's a need for a more public engagement, a more public discussion. There's a need for a study effort to work on a particular issue with experts in the room. That is all valuable. And we also do it because we're not happy with how things are happening with our state agency. And in these efforts, well-meaning and productive efforts in many ways, we have created duplications of study efforts. For instance, and this is what we've changed in sub before you today, 9070, both DCH, the Behavioral Health Council, and the Office of Health Strategy and Coordination, all three have a duty worded in slightly different ways to create a prescription formulary. That's obviously an overlap of duties. And what this bill does is put that duty directly only in the Office of Health Strategy and Coordination, and direct them to give them a timetable, not only to study it, not only to think about it, not only to create a task force, but to do it by January 1st, 2023. I think that will move the ball. And come January 2023, if I'm back, if this bill passes, I'll be interested in where is the formulary. In talking about this overlap and duplication, I've consulted with the behavioral health folks and had a long conversation yesterday with Grant Thomas. And I said, and DCH, y'all need to talk here. Y'all need to talk about these duties and how we can accomplish these duties. And I think we have to put some responsibility and some deadlines, and we have to eliminate some of the duplication. Let me bring some good news to this committee that I think a lot of what we're talking about is good news, but I learned this in the Judiciary Committee. We have a bill to address a particular settlement of the opioid settlement. There's multiple litigations, but Georgia is participating in one, and Georgia is more than one, but this particular one, we passed this bill to address what our obligations were on the settlement document. $600 million is coming to Georgia for opioid relief. And immediately, I think immediately is defined not maybe in the 22 budget, but the 23 budget, $88 million for opioid substance abuse treatment. I think that's something that I want to participate in. And if we have this bill that clearly includes substance abuse treatment and additional new monies from these opioid settlements, there will be others coming. I think that it gives us additional opportunities. Representative Hutchinson's issue about administrative cost and an accounting is set forth in the bill. We have a provision in there. We're going to look at this issue, and I believe that's on line 1923. Madam Chair, we've done some smaller things about adjusting some definitions and to include some statutory correct references, none of which we could have done without Ms. Howerton, of course, who is our essential quality control check. I'm very pleased with our efforts, and I think there's obviously always more work to do, but I think at each step of this, we have made progress. And I'm going to ask for the committee's favorable consideration.
Absolutely. I concur. No, just a couple things to add. First and foremost, thank you very much to Chairman Oliver for starting out the review. Let me go ahead and give you just a few other changes because they came either directly from this committee or the student finance. We had other agencies, and I just want to make sure if they're not reading through the 80 pages, they're probably going to read through it quickly. So just want to make sure to Dr. Newton's question regarding the social determinants, you'll see in the medical loss ratio, section 370 to 407, we paired that up with the 1115 waiver and the 1915 waiver that's in the existing federal law. So we feel comfortable in terms of how that will be initiated. In terms of, it was brought to our attention by, I believe it was the GHA, that we had an inconsistent definition around mental health and substance use disorder within the statute. We appreciate them doing that, and we went ahead and made that consistent across the statute. The Student Finance Commission let us know that we had a little bit too broad of a definition on the mental health and substance abuse specialist. So we went ahead and we tightened that up and we put that at the determinant of the department. And I believe Chairman Oliver and I just wanted to mention it again because it was mentioned so many times during public comment, Madam Chair, around making sure that we're doing as much as we can on linguistic, language, and cultural, that in fact that is in there, that has not been touched on this sub. We feel as if the last sub did hit it appropriately, and we continue to value and are open up to additional comments from not just the public, but the agencies and of course the committee.
I think I would like to end something we both feel very strongly about. The definition sections and the parity section have not been changed. We've had many suggestions from many providers, CMOs, and insurance that we make adjustments to those definitions. And we feel very strongly that this is a strong parity bill. We're not making changes there. In the medical spending ratio, I like your term better than medical loss ratio. We're also sticking strongly by that provision.
And certainly have my backing on both those issues also. So there. So, all right. Do we have questions from the committee? I mean, I feel sure that this bill is going across to the Senate. If members come up with questions after they've had an opportunity to read the bill, I wish you would direct them toward Representative Oliver or Representative Jones. Representative Hutchinson.
This one doesn't work. Thank you. I think the changes you made are great. I just wanted to make a comment that the method to my madness about trying to slim down the system is right now in Georgia, if you have a child with a reactive attachment disorder diagnosis or conduct disorder diagnosis, these are kids that are killing things and setting fires. Georgia does not have a single bed, not a single bed for those kids. We have to send them out of state. So it's my thought, and this is just me, if we can slim down the system, which is what I always try to do, maybe that money can go into a facility or even a farm somewhere in the middle of nowhere, which is best practice. Maybe we can do something for those kids, because you can imagine when you have a child with that severe diagnosis, we can't offer the parents anything. And in policy, we cannot treat them either. If there's a reactive attachment diagnosis, conduct disorder, we're forbidden. So not only are providers forbidden, there's no place in Georgia for those kids to get any kind of care. So I'm not doing this just to make your life miserable. That is my goal ultimately, not with this bill, but like the speaker said, years of the conversation.
The providers are getting a 10% increase, and in the deep end of the pond where we are spending $200 less a day than Tennessee does for the most intensive psychiatric bed for children in Georgia. That's a big discrepancy, and only a minority of the children in youth villages are Georgia children. The rest of them are out of state for other reasons because of the Tennessee pays $600 a day, Georgia pays $400 a day. There's a reason that we're not serving Georgia children. Around 2000, I went to the 11th Circuit on a case of least restrictive environment on special education for residential treatment out of state. The federal appellate court said that it was a failure to do least restrictive environment under the special education law to send a residential child away from his home state. Todd D versus Andrews. So we go to court and we win these cases, and 20 years later, it comes down to the providers and what do we do in Georgia to make the providers compensated, appreciated, and respected.
Well, I certainly echo Representative Hutchinson's concerns. We have a youngster on my street in a very loving family, adopted when she was 4, she's 12. And finally, as last resort, she is at a Florida farm for the last 5 months, working on the very issue that Representative Hutchinson mentioned. Luckily, that family has the means to help. They told the other 3 children that there would be no swimming pool this last summer, which is, of course, and they voted, and along with the family said immediately, we want Izzy to get better. And so we can certainly do without a swimming pool for as long as it takes. So very proud of that family for doing it. But it is a problem when you have to send youngsters out of our state.
And again, it's the crisis percentage of our mentally ill population that we're spending our energy, time, and hopefully improving opportunities for treatment and service.
Representative Dempsey.
Yes. Thank you, Madam Chairman. Thank you to both of you and to the speaker for the huge amount of work that's been done on this effort. Representative Oliver, I know that you have served with me as well all these years, and we've had so many conversations. It's been about 10 years, actually, at least, maybe almost 11, maybe 12 budget cycles. I don't know. I feel like I've been there working on that and the challenges that are faced, and we've done all that we could with all that we had. So we're in a unique time where perhaps we can do much more. The conversation, I know, is very robust. I will say the bill is very robust. It addresses a lot of things. Representative Hutchinson and I have talked about how many layers there are. I want to tell you, first of all, I think there are a couple of really good things that are in this measure. I am so 100% in the conversation of parity. I think it is the top issue that we must address. The loan forgiveness. So I understand that nurses were added. Is that correct? Also, was there Is there more loan forgiveness beyond? Yeah,
Yeah, Chairman Dempsey, yeah, we did expand the roles and we also gave the department flexibility to be able to expand upon what a mental health professional and specialist is,
okay.
knowing that today we don't know everything. In 2025, things could change and we didn't want to have to come back to the General Assembly for that change.
Right. So however, that definition works out and whoever can be a part of growing and expanding the workforce is paramount to what we do. Because I have great concern about offering things that we cannot deliver because we do not have those workers. I want to just continue to encourage you to follow all of that. You know, we put raises in. We hope that really helps. We hope that helps for retention. Not sure exactly what's going to happen with recruitment on that issue, but certainly loan forgiveness and educational encouragement is so important at this moment to be able to deliver. As I said, I think though that is the impact on direct services, and it's hard to see throughout. As I know we just received this one this morning, so I haven't been through it as deeply as I want to. But the focus on direct services, I think we have to remember why we're here. And I know many of you know that. I know many in this room know that because you work or you have someone that you love that also is impacted by sometimes the lack of services and the lack of access to it. So that is so important. I do think the bill and the conversation that we're in impacts stigma in a positive way. And it opens the door to more conversations that I hope will continue. I hope that it is uniting people as we move forward in this. I do want to go back to one thing though. So I said all of that because it is so positive. There is one place where I do have great concern, and it comes to our mobile crisis units. I'm going to tell you quite frankly that the term mobile crisis unit, I think, is somewhat confusing. It's much like when we had the settlement and it was talked about, and we will have services in community. And the general interpretation of that to people was that we are going to close hospitals, one in my area particularly, and people are going to suddenly be in community without what they need. In some cases, that actually did happen as we had to act pretty quickly on it. I think people see that mobility as, you know, it's the driving to, it's the transporting, that they are mobile in the work they do. They're actually not. They are more about mobility and about trying to get there quickly. But these are regular, normal people that have serve on these teams. Some are very specialized, some are very equipped and trained to do it. Some are clinicians in their own private vehicle getting there quickly to meet that hour, that golden hour that we're trying to do. They show up sometimes in t-shirts and jeans. They're ready to de-escalate and evaluate a system, a situation. It is up to each and every individual county at this time, though, to deal with that transport problem. It is not the mobile crisis units, mobility or access to that to do it. And it's actually, you know, they've not been hired or equipped to do that transport. That's not in their job description. That's not what they do. They're national standards and guidelines that they are fulfilling, and the great work that they've done as we've tried to bring them to that. But we face July 1 of this very year. It is essential that we go into the 988 system. There's a lot of work for that to happen. And these crisis workers are the ones who we have to do that. So if we do anything to add to their work burden right now without equipping them to do that, I feel that we could lose that existing workforce and we can't meet what we are called upon. So they are critical workers and they are critical to the 988 development. So as we go forward in that, I know we're going to have more and more conversation across the hall and as it comes back. I just want to make sure that we do not step on anyone's toes and discourage that level of employment. We will continue, as we have for all of these years, to talk about transportation. It's a challenge and it always will be, but counties right now are charged with that burden. And until we change that or find a way to fund that, we need to respect that. So just wanted to make sure I said that.
You want to go first on this? second?
It's an issue that I am frankly not clear on who's doing what where. I do think the CSBs and the crisis units have opportunity, and the healthcare facilities have opportunities to work together on the transport issue. And I'm hoping that the language we put in there with some funding opportunities and with some real analysis will move the ball forward. It is about our crisis population of our mentally ill population. And that is where we are seeing the most injury to people, them, not us, them. Mentally ill people are injured by that. And the families are in stress about it. And the mobile crisis units and the CSBs and the emergency room folks, if I were running a hospital, I think that this would be a high priority for me to figure out with the CSBs and with the mobile crisis units.
I think Chairman Dempsey, this has been talked about a lot, and I think will continue to be talked about. Matter of fact, in Chair Cooper's office, I think we must have spent it, I'll say a lot of time on it in our multiple meetings. That's why I think I see Chair Cooper affirmatively nodding. We did make some changes, and I know you guys just got the bill this morning. It's light reading, so it shouldn't take you too long. But ultimately, I think you'll see we continue to double down on the mobile crisis units. And I think a lot of that, at least from my own personal perspective, comes from my business holdings. I've never seen a team greater than 5 people be, I'll say, as functional as a team around 4 people. I like to see a team that's smaller. They're a bit more, I'll say, focused, and I'll say politics don't get in the way, but rather getting the mission completed is really what we see. And I think we see that across the board in terms of success. I think you'll see that we talked about initial safety in terms of what we're asking the mobile crisis to do. And then also the county in terms of coordinating with law enforcement around their responsibility for initial safety. And that's a change you'll see in this sub. And then finally, you'll see later on in the sub that we talk about transportation in terms of that emergency facility coordinating with either law enforcement or a private entity. So again, we don't necessarily believe we've hit perfection, but we're getting closer to what we think is something that we think is going to work. We'll continue to work with the folks, knock on wood, assuming we get a due pass here and we get it off the floor. We'll continue to work with the folks across the hall to see if we can make it even better before sine die.
Sounds great. Thank you. I appreciate the work y'all have done.
Representative Sharper. Where is, you're online? It's online. Representative Sharper?
Okay, can y'all hear me okay? Hello?
Hello? Okay, we're getting you.
Okay, you hear me? First of all, thank you guys for being here. One thing that we got to consider when we're looking at the transportation piece and even the mobility, even though if you have the people in the right places to go and handle these crises, the biggest thing is going to be a facility that they're going back to. For several years, probably the last 30 years even, when EMS and people like that are called to situations where there's a mental situation, of course, a lot of times we're going to be calling law enforcement to make sure everybody and everything is safe. So the trend was basically take the patient to the hospital, and then they're in the ER, of course, and then nothing really can be done until you get someone from a private company there that handles mental cases. And so you see that log that we've had for years with that. And another thing, or the alternative, if you don't get a mental crisis personnel on the scene, and if EMS doesn't think that that patient is safe to even transport, then it falls into the hands of law enforcement. And then law enforcement has 2 things they're going to do. If they're not trained, they're going to end up with that patient possibly in the jail, where they shouldn't be, or they're going to eventually even end up at the ER where they really shouldn't be. But we've seen some great things happen in the Valdosta, Lowndes County area with Legacy, to where if you have the crisis situation, they're able to go to that patient, do what they need to do, and take them to their facility, long as it's not life-threatening. So I think we just need to keep that in mind, that there are so many more people that are actually not having life-threatening situations where they need to be transported by EMS or to the emergency room, but it's just a matter of getting them to their crisis center. So I just want to put that big picture out there of what we're looking at. So making not only the teams, mobility teams, crisis teams a priority, but making facilities, even a smaller facility that they can go to where they can get these people calmed down and also get them the attention they need immediately as far as their mental health. But I just wanted to show you what's going on and what's a possible solution if we focus on it.
First of all, thank you so much. We've heard that on several occasions. We feel as if some of the sub is starting to get towards that, just like we mentioned to Chairman Dempsey, though we don't necessarily think we've hit it perfectly. I'd also like to mention that Representative Barton was kind enough to walk us through times where an individual is transferred from where they received their assessment to, I'll say, a place where they're going to be going for either, a step down program or some type of acute care. And if they even missed one piece of paper, they then have to transfer them back to the original medical facility, get the piece of paper, and then literally get them back to the other facility. The problem is the other facility by then most likely has given away the bed. So we are tracking down that statute or reg, whatever it is that was formed sometime before the Depression, and bringing us into the 2000s so that we're going to use this little thing maybe called email, electronics, something to the effect that we don't have people going back and forth. So I think those are the type of things, people who are on the ground, we need that information. We appreciate you telling us during committee. Representative Barton was kind enough to take me aside and have that conversation. So thank you, sir. We'll continue to try to incorporate all of that. We're still chasing down that statute or reg because we think it is equally, I'll say, the definition of insanity.
All right. Thank you. Thank you.
You, Representative Sharper. Representative Newton.
Thank you, Madam Chair. On page 15, where you did address the medical loss ratio, trying to get money spent on care, at least 85%. I really appreciate that. I think that's a key thing for all our facilities and our providers, like Chairman Dempsey mentioned. One thing you had mentioned, and just curious, is kind of a follow-up question to something you had mentioned in an earlier discussion of this, was that you're setting a minimum bar, but there's nothing to prevent a care management organization from, say, putting in a bid at 86 or 87, or I think you mentioned Tennessee or somewhere had a 95%, 90% number. Just as you go through the process, just a question, is there a way to encourage the department as they evaluate bids for care management organizations for all of healthcare, but also including the parity with mental health? Is there a way to encourage the department to pick those that might be willing to go to 90% medical spend ratio instead of 85, or is that just going to be an understanding that that's what we would expect out of our executive branch, or is there a way to encourage it as you go through the process?
I'm trying to remember when the contract is up, CMO's contract up. I think it's in the next year. And if I were governor,
Thank you,
I would
Madam.
pay attention to that and look at why the other states seem, on the surface at least, to be getting a much better contract deal for the taxpayer. I think it is a leadership issue on a critical issue. And if this bill passes in this form, where we do say 85% or higher, that was one of our first amendments we put in.
That's right.
We'll have a better encouragement of folks to
Yes.
approach that contracting opportunity with a more positive view.
Yeah, Dr. Newton, I vacillate on that, to be completely frank with you. There is part of me that I would like to legislate that. There's another part of me that hopes that the executive branch would use its discretion appropriately. The other thing is there's so many unknowns. For instance, we'll use Tennessee and Florida. They have a slightly different definition of mental health. So that means, as they say, they're doing 87 or 90. It's not necessarily apples and apples. It could be still two fruits, but it's not necessarily the same thing. So I hope, I wasn't sure, or I should say we were not sure, could we legislate it to the point where they cause the common denominator, a common numerator, just like you learned back in, I think Algebra 1, and then be able to make that comparison, apples to apples, or, whatever cliche you want to use. So to us, we left it slightly more towards the discretion of the executive branch to, we hope, say, well, same price, but higher MLR, Okay, I think that's clear. But if it's not the same price and possibly it's higher, but you have a higher MLR, I think at that point, then we're hoping that there's a lot of smart people get around the room. And if Mary Margaret was governor, I hope she would call me and then we would go through what that analysis would be.
Thank you. Thank you very much. I know you guys have said this is a first step, and I guess setting the bar at an achievable rate to make sure we get plenty of bids is certainly crucial, and I appreciate y'all's work on it.
Representative Beverly.
Thank you, Madam Chair. To that point, line 381, which is to Representative Newton's point, line 381 says, subject to the receipt by the Department of Community Health of a waiver pursuant to Section 1115 or Section 915B3 of the Federal Social Security Act. If I'm not mistaken, in December of last year, wasn't the work requirement under 1115 suspended? So why are we tying this to the 1115 waiver? I'm not sure why that is in this here when it was severed.
Yeah, here's what I think is true. I think that we offer different waivers for different amount. And the fact that we're in litigation right now is a problem. It's a problem. But I think that doesn't prohibit other waivers. That's how I understand it.
Yeah, and I concur. And keep in mind, that's really around right now, we're limiting that to the social construct and the social spend. Because if you continue down that line, you'll see as it speaks to around what the social spend was. And the concern that the committee brought up last time was we didn't align to the federal act, but we also had not placed a cap on it. So we felt as if putting that back in, we felt made it a slight bit stronger.
And that is the way that it happens. It seems like even the tiniest thing we want to change, we have to ask for a waiver. And, 1115 is one of the ones that frequently gets used. So, right. Okay. Representative Beverly did his. Is there anybody else on the committee that would like to ask a question or make a comment? Well, what is how does the committee feel about the bill? What would you like to do? What's the stat? We got a move to pass in a second. All right, we got a move to pass in a second. There is an amendment. Would we want to go ahead and offer your amendment? Representative Houston.
Thank you, Madam Chair. I'd like to move that the committee adopt AM 332001, which is on everybody's desks. Friendly amendment, and I'll defer to Chairman Jones, despite that Florida Gator tie, to explain the amendment.
Well, first and foremost, I did give deference to your alma mater yesterday in the well. I felt the least I could do for the committee is have you look at my orange and blue tie for the entire session, hoping that would reduce the amount of questions from the Georgia Bulldogs. That stated, if you do have this amendment in front of you, you will see in the sub, we effectively wanted to modify a little bit tighter. Bravo RB really speaks to a Supreme Court case, and we wanted to make sure that that language provided for the support of that Supreme Court case and tied that into the Georgia law. In terms of C, we feel as if that also goes towards SCOTUS and then also towards making sure that from a practical standpoint, we have a least restrictive alternative. And then finally, who has declined voluntary inpatient treatment. So we feel as if this wording, a little bit more efficient, also a little bit more parallel to what the SCOTUS case was. And we hope that the committee sees this as an amendment that should be incorporated before there's a full vote on the bill.
Questions on the amendment to the authors? Okay. No questions? Okay. Everyone in favor of the passage of amendment AM 332001, say aye. Aye. Anyone opposed? No. Okay, the ayes have it. Now we are back to the bill. Is there any more discussion on the mental health? I'm not calling it the 1013 bill. Do you have something you'd like to add?
Is the motion before the committee do pass committee sub as amended? Is that the specific?
Yes, so it'll be. Okay. All right. We have that. as Representative Oliver said, it is for a substitute to the committee sub as amended. Got it right. Okay, so no further discussion. Everyone in the favor say aye. Anyone
Aye.
opposed? No.
Aye. Aye.
It- Is that the audience? Okay. Anyone knows? Okay. All right. Now it's on its way. We'll get it out to rules. And I want to watch and be sure I'm at rules, which I am. When y'all explain this bill in the 1 minute that the rules chairman gives to it be explained. Okay. So to the committee, don't go away. We're going to pass out another short bill that we have and but we are finished on the mental health parity.
Thank you.
Will that be Friday morning? You did the whole, or they did the form.
Excuse me, to the audience, excuse me. At the audience, if you want to discuss things, please take your discussion. We have another bill that we need to consider and the noise level is all that we can't. Thank you for coming. Does the committee, did you all have a copy of Senate Bill 256? Representative Hutchins? Okay, so we can get out of here and for people to go to other meetings. Sorry. All right. Does everybody have a copy of the substitute to Senate Bill 256 LC 339047S? This bill is about products that contain, and if I can say the word, let me find it, dextromethorphan, or DMX as it is called. Did I get close? You know, like, go ahead, say it out loud.
DMX works.
DMX, it works really great. This is found in cough syrup and other like products. And the kids are doing what is called something with robo, and they're using it to get high. It's extremely addictive, very detrimental to brains. They are buying it in big quantities. Over half of the states have passed a rule like this so that it's not sold to 18-year-olds. And if it, they have to check, and anybody under 18 years of age. This passed out of the Senate and got hung up last year in our one of our rules committees. It is the retailer pharmacies were all in agreement about this last year, and they did add a purchase about, since people could not purchase in pharmacies when we were going through COVID, about online and what you have to do about that if a cough syrup is being purchased. So basically, we are trying once again to protect young people who decide they're going to screw up their brains and become addicted to what they can find in our drugstores. Give y'all a minute to. Is there anybody who would like to speak to the bill? Nobody? Okay. Who's this? Representative Hogan.
Make motion do pass.
Okay.
Second.
All right, we have a motion do pass and second. Do we have any questions for? Okay, we have a motion. Everyone in the favor of the substitute to Senate Bill 256 LC? Huh? Do you have a question?
course I do. What is, what is the street name for this? Is it just CMX? Or is it like bath salts or?
I mean, what they call
Gummies
it
or-
is, I'm trying to find it. Lean. The
Lean,
extra,
okay,
lean.
gotcha. Now I
got
know what
it?
you're talking about.
but the lean,
Lean.
Lean, but what they do with it, it's called Robo something. I had it in where somebody had sent me what they call it. Anyway, what will kids get next? Okay, everyone in the favor of the passage of Senate Bill 256, LC 339047S, say aye. Anyone Opposed, no. Okay, the ayes have it. Thank you very much. Thank you for your attention to our big bill and for this one.